Hello and welcome everyone. Today we will be discussing this paper on restrictive or liberal transfusion strategy in myocardial infarction with anemia, the MINT trial. The prevalence of anemia in AMI is actually very common. Now, there is a controversy regarding the strategy that should be used regarding blood transfusion in AMI patients. And since there have been a lot of studies in critically ill patients where it has been shown that transfusion should be done when it is less than 7, but in AMI patients, there is a lack of any substantial evidence. Now, there have been three small RCTs involving 820 patients with AMI, which showed inconsistent results regarding the transfusion threshold that should be used. Now, the largest among these trials indicated that a restrictive transfusion, that is at a lower hemoglobin level, was as effective as liberal in preventing major adverse effects due to cardiac origin within 30 days. Now, the potential benefits and risks might the benefit is that it will reduce the ischemic injury by improving the oxygen delivery, but it also has a side effect that it will increase the volume, thereby possibility of exacerbating the heart failure. Because it is a foreign substance, there is a chance of infection. There is also risk of thrombosis and inflammation. Now, studies involving over 21,000 patients comparing restrictive and liberal strategies have shown a reduction of 50% in blood use without impacting morbidity and mortality. Now, guidelines highlight the need for more clinical data in AMI patients for determining an optimal strategy. So, based on this background, the MINT trial aimed to evaluate a restrictive transfusion strategy, that is 7 to 8, versus liberal, that is less than 10, and see the impact on the risk of death or myocardial infarction in anemic patients with AMI over a 30 days period. It was an open label randomized trial conducted at 144 sites across United States, Canada, France, Brazil, New Zealand, and Australia. Now, it was approved by the institutional ethic boards of each site. Written consent was obtained from the patients or their surrogates. It was designed and led by executive and steering committees with members from various centers, trials, and the National Heart Lung Blood Institute. The first two authors wrote the initial manuscript draft, ensuring data completeness, accuracy, and adherence to the protocol. An independent data and safety monitoring committee reporting to the National Heart Lung Blood Institute reviewed the unmasked data semi-annually for patient safety and conducted annual interim efficacy analysis. The eligibility criteria for the trial were adult, that is more than 18 years, with ST elevation or non-ST elevation myocardial infarction with anemia, which was defined as hemoglobin less than 10 within 24 hours before the randomization. The inclusion was based on the third universal definition of myocardial infarction, including all the types of infarction. The exclusion was uncontrolled bleeding, the patients who were receiving palliative treatment, who were scheduled for a cardiac surgery during the admission, or who declined blood transfusion due to religious practices. Now, trial staff identified eligible patients with MI and low hemoglobin during hospitalization, confirmed the eligibility, and attending physician's approval was done. Then the randomization one was done. Patients were randomizedly assigned into 1:1 ratio to either the restrictive or the liberal group. They utilized a web-based system, a permitted block design with variable block sizes stratified by the clinical site. Randomization sequence was generated by an independent statistician at the Data Coordination Center. Restrictive strategy group. Transfusion permitted but not mandatory when hemoglobin is less than 8. Strongly recommend transfusion if hemoglobin was less than 7 or there was uncontrolled anginal symptoms. Liberal strategy was immediate transfusion of 1 packet of PRBC after post-randomization because the hemoglobin was less than 10. The goal was to maintain the hemoglobin as more than 10 until the hospital discharge or for 30 days period. The common protocol aspects was the transfusion administered 1 unit at a time, followed by the hemoglobin level assessment. Transfusion protocol could be paused for immediate need like active bleeding. In patients with volume overload, transfusion delay until after diuresis or dialysis day for those with end-stage renal disease. Post-randomization, the randomization strategy was known to the site investigator and the patients. Regarding the assessment, in the initial assessment, ECG, hemoglobin, troponin levels were measured within 24 hours after randomization and daily for the first 3 days. For follow-up, telephone contact to assess the vital status, quality of life, hospital readmission, and emergency department visits were done. 6-month follow-up was done with telephone. For patients readmitted within 30 days of post-randomization, reviewing of the clinical events and troponin levels were done. So the outcome was composite myocardial infarction or death from any cause within 30 days of randomization. The other events were clinical event committee blinded to the treatment assignment adjudicated the myocardial infarction using the definition of the third universal definition. So this was the committee's decision to attribute a particular death to be originating from myocardial infarction origin or any other cause. Now, in the secondary outcomes, individual component of the primary outcome plus outcomes like ischemia-driven unscheduled coronary revascularization or readmission for ischemic cardiac conditions within 30 days were taken into account. For the statistical analysis, the sample size was calculated based on an enrollment of 3,500 patients to achieve a 80% power, aimed to detect a 20% relative difference between the groups in the incidence of the primary outcome. Assume an overall incidence of myocardial infarction or death at 16% and utilize a two-test with the alpha level of 0.05. The intention to treat analysis was done. All analysis was conducted based on this analysis and two-sided hypothesis test for superiority was employed. Risk ratio assessment used to compare the risk between restrictive and liberal group. The values of greater than 1 indicate a preference for liberal strategy. Primary analysis method was implemented by log binomial regression model and included fixed effects for assigned transfusion strategies and random effects for clinical sites. So let's come to the results. In this, 3,530 patients were given for consent and 24 were ineligible, 3,506 were randomized, 1749 in restrictive, 1757 in the liberal. Out of this, complete data was found in 98.9 of the restrictive, 97.8 of the liberal group. So overall analysis was done based on these two subsets. So if we come to the demographics, the age was 72, the female sex was around 45%. In terms of race, mostly it is white, 70%, followed by black, 12%, others is around 7%. In the medical history, myocardial infarction was 32%, percutaneous intervention was running 34%, CABG in 21%, and heart failure in 30%. Angiography, result available before randomization in 50%, and multivessel coronary artery disease with more than 50% obstruction in 65% of the cases. For left ventricular ejection fraction, the ejection fraction was around, for quantitative assessment was available for around 2,558 patients. Out of this, the most recent result showed around 47% of ejection fraction. NSTEMI was found in 81%, type 1 MI in 41, and type 2 in 55. Most of the parameters were comparable between the two groups. So if we look at how the strategy was implemented and what were its effects, you can see that initially both groups had a baseline of 8.6 of hemoglobin, which increased to 10.1 in the liberal group, which remained at 8.8 in the restrictive group. So it remained throughout the 3 days period. So as we can see over here, they were able to achieve a difference of around 1 gram per deciliter of difference in the hemoglobin levels using this particular transfusion strategy. But there is a gross difference in terms of units of blood used. Now, if you see over here, no blood was used in 66% of the cases in the restrictive strategy, while almost all the patients did receive transfusion in the liberal group, with almost 33.9% receiving more than 3 transfusions. So nearly 4,325 units were transfused in the liberal group, while only 1,237 was transfused in the restrictive group. So if you look at it over here, definitely they did find a significant difference in terms of the usage of blood transfuse, and also a difference in terms of the level they were trying to achieve. Now, if you look at the primary outcomes over here, as you can see, if it is more than 1, it will favor the liberal group. It is less than 1, it will favor the restrictive group. Since most of the lines are crossing the midline, almost none of the parameters are within significance. So if we look at it, though most of the values are favoring the liberal strategy, but since they are crossing the midline, that is the point of 1, we cannot say that it is statistically significant. So most of the parameters, that is the primary outcome, either it is MI or death, or the individual outcomes like death, MI, and the revascularization cardiac events, all are not showing any difference between the two groups. Only in terms of cardiac death, we find a significant difference, but it is in a very small subset of patients, so it has to be reviewed further. And in terms of where we found less effect or better effect in restrictive, we found better effect in terms of heart failure, in terms of the pulmonary embolism. Surprisingly, pneumonia or bacteremia were slightly less in the liberal group. So this is the diagram which is showing the primary outcome. As you can see over here, the restrictive strategy has a higher incidence of cardiac events, but this difference is not statistically significant. This is the composite outcome, this is death. In both of the outcomes, it is slightly more in restrictive group, but not statistically significant. In terms of subgroup analysis, again, if it was more than 1, it would favor liberal, but it is not really like that in any of the subgroups. Most of the lines are crossing the midline. The only subgroup where we can see some kind of a difference is in this type 1, where you find that it has somehow favored the liberal group, and in heart failure, where there is heart failure prior to the admission. So the limitation of the trial, health professionals were aware about the transfusion strategy, and this could have influenced their management decisions or the interpretation of the outcomes. This is very important because the outcomes are being interpreted by the clinicians, and the management decisions is obviously also made by them. So since both of these can be influenced by an open label trial, so their personal biases could have influenced these assessments. The classification of the cause of death. Although the death from cardiac cause was a pre-specified outcome, it was not a primary outcome or a tertiary outcome and was not adjudicated. Less than half of the deaths were classified as cardiac, which may affect the accuracy of the outcome measurement. Now, the myocardial infarction that qualified patients for trial and other outcomes except for the subsequent MI were not centrally adjudicated, potentially leading to variability in the outcome classification. Now, in the liberal group, the adherence to the hemoglobin threshold of less than 10 was moderate at hospital discharge, that is 86.3%, with deviation often based on clinical judgment such as concern over fluid overload or timing of the hospital discharge. Now, the analysis did not adjust for multiplicity, meaning that the statistical analysis of the secondary outcomes may be less certain, and caution should be applied when interpreting these results beyond the primary outcome. The next is the decision to whether transfuse is a common one in clinical practice for patients with acute myocardial infarction. The trial observed that 95% confidence interval for liberal strategy did not show a clear clinical benefit for the restrictive group. At 30 days, there was a lower risk of myocardial infarction or death by 2.4% in the liberal group compared to the restrictive group, and it was overall 1.6 percentage point lower risk of death. So we can conclude that in patients with acute myocardial infarction and anemia, a liberal transfusion strategy did not significantly reduce the risk of recurrent myocardial infarction or death at 30 days. However, the potential harms of a restrictive strategy cannot be excluded. So overall, the take from the trial is that we can use the restrictive strategy in acute myocardial infarction and may target a level of around 8 because that was the level which was achieved in this particular trial. Though they were looking for 7 to 8, it was mostly above 8 only in throughout the period the patients were in the trial group. So this study may add important evidence in terms of the positive impact of using the restrictive transfusion strategy in reducing the usage of blood transfusion products in patients with acute myocardial infarction with anemia. Thank you for your patience.